Okay, well, thank you very much for the opportunity to do this interview for ESOC in Lyon. We're very much looking forward to coming over there. And I'm going to be presenting this study, which is the treatment of hyperglycemia in acute stroke. And this is the results from the Trial of Exenatide in Acute Ischaemic Stroke study, or what we know as the TEXAIS study. And one of the issues about the treatment of hyperglycemia in acute stroke is that it's very common. Up to 50% of patients at admission have hyperglycemia. And indeed, in the TEXAIS study, it was well over 40% had hyperglycemia on admission. And one of the issues with hyperglycemia is that it causes significant problems. It results in poorer outcomes for patients with stroke, and particularly in the context of patients who are getting mechanical thrombectomy. They also tend to have worse outcomes. And we've been looking for different ways of treating hyperglycemia for quite some time. And one of the obvious ways is to use insulin therapy. But as we've seen from multiple studies, including even the recently published SHINE study, insulin therapy is difficult. There's problems of hypoglycemia, and in some studies that can occur in up to 70% of patients getting insulin. And of course, it's very resource intensive. And indeed, studies have shown that, in fact, even using insulin, you don't get any better outcomes. And some studies have even suggested there are worse outcomes in terms of infarct growth on the MRI. So we decided to look at this from a different perspective, and we looked at some of the newer diabetes drugs, in particular the GLP agonists. And there's a group of drugs known as the incretins, and the incretins are gut hormones that have a pretty unique feature in that they reduce blood glucose, but their action is actually glucose dependent. So as the blood glucose level drops, then the action of the drug diminishes. So we looked at a particular drug called Exenatide, particularly the short-acting version of Exenatide, and that has an action within 2 hours of subcutaneous injection. So it's ideally situated for the use in acute stroke, whereas some of the other diabetes drugs have longer mechanisms of action, and they take hours to several days to kick in. Short-acting Exenatide kicks in within just a few hours. So the TEXAIS study was looking at using Exenatide twice a day subcutaneously within 9 hours of stroke onset. In other words, targeting the ischemic penumbra, trying to improve stroke outcomes. It's a multi-center, phase 2 multi-center prospective randomized open label study, a probe trial design, ran over 15 sites, including Christchurch in New Zealand and Helsinki in Europe. And the primary hypothesis was an ambitious one. We're looking at the improvement in neurological outcome as an 8-point improvement in NIHSS or 0-1 at 7 days. And we also had a number of secondary hypotheses, particularly looking at 90-day NIHSS and 90-day Rankin scores. So we recruited about 350 patients. We initially were aiming at 528, but unfortunately, as with many studies, COVID and time constraints caused significant problems for us, and the study was finished at 350 patients after about 5 years. Now, between the standard care and Exenatide groups, there were no major differences in all the key variables. There was no difference in age, sex. There was no difference in a lot of the medical comorbidities, in particular, no difference in diabetes between the two groups. So in terms of the outcomes from this study, as I said, it was an ambitious primary hypothesis, and we showed that between standard care group and the Exenatide group, there was no significant difference in the primary outcome of improvement of 8 points in NIHSS. There was an improvement in 56.7% of the standard care group, 61% of the Exenatide group, with an effect size with an adjusted odds ratio of 1.22. And while I would like to think there was certainly a trend there towards better outcome in the exenatide group, the p-value was 0.38. In terms of secondary outcomes, there was no significant differences in 90-day Rankin scores, NIHSS scores, and there was no difference in death at 90 days between the two groups. Now, one of the interesting parts of this study, the TEXAIS study, was looking at the profile of hyperglycemia and hypoglycemia. And basically what we looked at was in each patient, the mean daily frequency of either hypo or hyperglycemia. And we took all those values and generated a median score across the group. So what we found, interestingly, was that there was a reduction in frequency of hyperglycemia in the exenatide group, and that was certainly statistically significant. Importantly, we found there was no occurrence of hypoglycemia in either group. Now, exenatide is a very easy drug to use, but it does have potential side effects of nausea and vomiting. And fortunately, we found that this was pretty uncommon. It occurred about 3.5% in the exenatide group, but was not overly severe and certainly was able to be well controlled with antiemetic therapy. So in conclusion, we found that in this phase 2 study, there was no significant improvement across the two groups in the outcomes at NIHSS at 7 days, but we did demonstrate that there was significantly less hyperglycemia in the exenatide group, and that there were no episodes of hypoglycemia. So clearly exenatide is having some benefit in terms of keeping glucose under control, reducing hyperglycemia, and this certainly lends itself to a further larger phase 3 study, which can look at this more completely. Thank you.